But welcome to members of the public. Welcome to the board. I'm not sure how many people have joined us, but effectively, please keep your microphone muted, and there will be time for questions at the end of the meeting. So we will start by introducing ourselves, although I think most people are probably known. So please, when I call you, just mention your name. I'm the chair, Mike Faraday. Michelle.
I'm Michelle Pace and I work for Healthwatch as the Digital Information Officer.
Amanda.
And I'm Amanda Cunnington, board member.
Adrian.
Adrian Barker, board member.
Aaron.
I'm Karen Swaffield, board member.
Andrew.
Andrew Sharp, Chief Officer, Healthwatch West Berks.
Adrian.
You've done me already.
Have I done you?
Yeah. But just in case of doubt, I'm Adrian Barker, as it says on the label.
Leslie.
Hi, I'm Leslie Ryman. I'm a board member.
Martha.
I'm Martha Vickers and I'm a board member.
Paul.
I'm Paul Wilson and I'm a voluntary board member.
And Nathan.
Nathan Pope, Digital and Social Media Officer for Healthwatch West Berkshire.
And Alice, I think.
Hi everyone, I'm Alice Clifton. I'm the Development Officer.
And I think that's all members of the board and Healthwatch staff. So, right, thank you for that. So we will move on to apologies for absence. I don't think we have any, do we, Andrew?
I don't think we do, no.
No, we don't.
Excellent, thank you very much. Declarations of interest. I don't really want any that we haven't already covered. So are there any new declarations of interest? Anybody wants to raise? No? Okay, right, we'll move on to the minutes and the matters arising. We've had the minutes for some time. Is everybody happy, or has anybody got anything to raise on the minutes in terms of incorrectness or anything that should be an action? No? Okay, then the minutes we will accept as acceptable. Alice, sorry, you. And we move on then to matters arising, which I don't think there are any. Is that right? Andrew, am I right? Nothing arising from last meeting?
I don't think so. Sorry, my phone isn't on silent because of
apologies, Mike. No, there isn't anything arising from the last meeting.
Okay, well, we'll move on to the action log, of which the first item is thinking together 5. Michelle has sent all participants a copy of the draft report. Have we had any feedback on that, Michelle?
No feedback yet on the thinking together 5.
So
it is actually now published.
Yeah, it's been published. It's on our website for everybody to find.
We can confirm that.
Yeah, I can close that action.
The next item is to do with voice of disability. That is actually on the agenda, is it not?
It is.
But in any event, it is ongoing. We moved it to the second quarter of 2022, so that's ongoing. Quality framework, that is still ongoing.
It is.
We don't have any particular update. And the CAMS report has been on the website.
Yep, that's been published. And it's people are able to see it now on the website.
So again, that one is concluded. And the community engagement, carers, is it that still ongoing?
Is that the carers survey, Mike?
It's the Carers Week, yes, the survey.
Yeah, that's still the survey's still ongoing.
Still ongoing. Okay, so that one will need to stay. Right, thank you very much. We now move on to item 4, and those lucky enough to have a copy of the agenda, the new agenda, will see that there are 2 item 4. So I'm taking the first item 4, which is to do with the ratification of a new board member. Board members will have received a CV of Julie, and I don't know if anybody does know how to pronounce. Do you know how to pronounce her name, Alice? My pronunciation is a little tricky. Or does anyone else know how to pronounce Julie's name?
It's Sigurdardottir.
Right. Okay. Thank you very much for that. It was the first bit I was worried about, actually, but Nihern or anyway,
Julie is fine.
Julie is fine. Not to worry. Everybody has had a copy of her CV. It seems to me that she would be a very welcome and excellent member of the board. Do we have any disagreements? And is everybody happy to ratify Julie as a member of the board? Lots of thumbs going up. Can't see Paul's thumb, but
Definitely,
okay,
yeah.
Excellent. All right. Thank you very much for that. Then Julie is duly ratified as a member of the board and will be invited to the next board meeting.
Mike, she may well pop up just to say a quick hello. She's got a corresponding meeting at the moment, or she would have been here.
Excellent. Okay, thank you very much. Right, so we move on to the second item 4 on the agenda, which is the report of the Chief Officer. Andrew, over to you.
Thanks, Mike. Lovely to see everyone today. And as Mike said, just filled with sadness that we are still in our little computer screens. I really, really thought we were going to be back in Broadway House with mince pies, coffee and smiles. So we may have the smiles. I'm not sure if we've got mince pies, but I'm really hoping that this is the last one of these we have to do where we are forcibly using computers and screens rather than speaking to each other in person. I think the first thing I wanted to do was update the board on some personnel changes. Both Nathan and Michelle are leaving us today. It's the last day. Both of them have been with us, I think, 4 years and about the same amount of time, or very similar. Both have made an amazing contribution to Healthwatch, the work we've done. And I think, you know, both have come on very much in themselves and learned lots, contributed lots. And, you know, I'm very, very sorry to be losing both of our team who have given so much. So hopefully joining all the board in wishing everyone best wishes for the future, keep in touch, etc. And of course, you are always welcome at Healthwatch West Berkshire, and should be very proud of everything you've achieved. In terms of since our last board meeting, we have been stupendously busy. Most of what I wanted to talk about is covered on the agenda, so I won't go into it in too many details, but the CAMS report has resonated significantly. Thinking Together 5 has been published, and there is ongoing debate about Thinking Together 6. We completed our patient story project for the frail elderly using the rapid response team, which is awaiting final publication. We have the quality framework and website to update for next year, and we've heard from Sir Robert Francis, and he's accelerating the quality framework. So we have to have moved on significantly by March of next year. So I've got some dates in the diary for board members who want to get involved in that in the new year. I suppose the other two big things have been obviously the integrated care system changes and the health bill going through Parliament as we speak, which is absolutely transforming the NHS, how it's run locally. So clinical commissioning groups will disappear as of April 2022. Yes, we are in 2022. Replaced with things like place-based partnership boards. The NHS has very helpfully decided to use the same acronym for integrated care partnerships that it's already using, and I think is used before anyway. So there is much confusion, very little clarity, and we will touch on it later on, but I cannot underestimate the significance of this. It really redraws all the maps in terms of who is responsible for what, where money feeds into, where responsibility ends up. I fear additional distance has been put in for the residents of West Berkshire, and should probably be mindful and watch that. And then finally, as just again, really significant development in the summer was we were asked to help very short term with the Health on the Move vaccination van, and both our staff and volunteers rocked up at very short notice to deal with the Health on the Move van popping up all over West Berkshire. Certainly the significant one I remember was the Kennet School one, which a lot of you were at, where it was the only clinic in West Berkshire for 16 and 18-year-olds that was opened up. We were oversubscribed massively. It was very, very challenging over the weekend. But subsequently to that, we were then commissioned by Public Health to help coordinate the community targeted COVID testing program, which is running daily, where the van and testing team go out to seldom heard communities, minorities, etc., to encourage them to test with a view to reducing health inequalities. So that has been an incredible project to be involved with, and I can only thank our team, our additional help that we got in, Julia Arnold, Liz Fisher, and most recently Julie Barker, who's seconded to us from the advocacy people but not here today, who have helped out with that and continue to help out with that. And of course we are busy with that all over Christmas, but we'll touch on that a bit further. So incredibly busy, but COVID still absolutely dwarfing anything else in terms of where else we're going with transformation, health inequalities, patient feedback, etc. It still seems to be somewhat overshadowing everything else. And our big concern is there are lots of things being left undone by it, and it's often used potentially as possible excuse for things not being as good as they should be. So we have to be mindful of this, that we don't get COVID blind in terms of our responses. Martha, you've got your hand up.
Thank you, Andrew. I didn't want to just stop your report, but just you expressed concern about obviously the changes in the management of our local health system and losing CCGs. Obviously, I'm just wondering how much, I think Healthwatch, is obviously, it has been trying to raise this as an issue. I mean, there's nothing much we can do to modify this now, I'm assuming, but do we have a role, or maybe working with the local council to try and make sure people as much as possible understand what is going on? Maybe some special debates, or at least our local leaders understand, because it's important that people know that we're having these changes. But the whole, this is why we've got Healthwatch, that the whole way everything's managed is so convoluted and dense that, people just struggle to get their heads around things. Hopefully on the ground, we're told nothing will change, but I can't believe that that's not going to be true. But I just wanted your thoughts on that, about how big an effort we can make locally to get the messages across.
I think I'd like to probably cover that off as the agenda item 10, Martha, so as I don't go into anything else, but I absolutely agree with you. And I think we should decide what role we're going to play in disseminating this information, inviting the residents of West Berkshire to be aware, comment, etc. So much of what's going on is unknown at the moment. It's really, really difficult to take a clear view. So let's come back to that and give some time to thought while we're going through the meeting, and we'll discuss it in some greater detail. Karen, you're on mute.
Thank you. I have a comment on that, and I'll bring it later on under the agenda. I noticed in the Newbury Weekly this week that there was talk, that there was mention of the work that you've been doing, going around with vaccinations, but I didn't see Healthwatch actually given any credit there.
Sadly not.
Which seems quite a miss.
Well, I think possibly. I mean, again, our role is not, we're not organising everything around, but what we are trying to do is make a difference for the vulnerable folk.
But the local authority was highlighted, and everybody else was given a positive stroke. I think it's a shame we were missed.
Yeah, I agree, and I think certainly the work we've done with Community United and things like the visit to the mosque was extraordinary. The work we've done with the rough sleepers. So I mean, if you wanted to write it, jot it down for me, I can put it through as a health article if somebody wanted to do that. I think what potentially we should emphasise really is that the whole vaccination testing effort is absolutely a partnership effort. The volunteers have been remarkable. They've absolutely kept it going. The various organisations who've been involved, largely, I'd have to say, in a positive nature, but there is the occasional department of one branch or other who seem completely unaware that testing and vaccination is going on and revert back to quite silly, petty stuff, which is disappointing. But yeah, I think someone bringing together how it all works, and also I think the problem we've got is expectations are being given nationally that can't possibly be delivered locally, or in fact anywhere, especially if you don't bother to tell the system before you've told everyone else. And it has been genuinely remarkable how fast things have been turned around, the capacity ramped up, but it's almost despite rather than because. So I think, this whole amazing system and partnership, and it does show West Berks is pretty blinking good at this. We have amazing voluntary sector, amazing volunteers, and we have got some fabulous local folk working at the clinical commissioning groups and in public health who've really got together. So we are quite lucky in a way. We are a little bit Goldilocks. We're not too big, not too small. We're just right in some things, and I think we've proved this. But we'll talk about that later. So if there's no other questions, that's all I really wanted to say. So as I said, an enormous thank you, and feeling very sad at people moving on. But on we go. On we go.
And I would like to echo very much your thoughts. And really, it is a sad day to see Michelle and Nathan move on. I know everything has to change, but I think we have been lucky to have had both those individuals here the last 4 years. And I'm sure we will survive, but my immediate reaction is, oh, what are we going to do now? Right, well, thank you. So Michelle and Nathan, I would like to wish you the very best of luck. I know all the board would actually echo.
Thank you very much, Mike.
So, right, we will move on to it's item 5, although Andrew has really have you covered it in its entirety, Andrew, other than the fact that it is an ongoing thing rather than a short-term event?
I think the only thing I just wanted to add was that we've been asked to continue till March, and this is based on a really moving feast. We don't know what's going to happen even this evening. We're expecting another announcement. And I don't think it can be underestimated how dangerous this current variant is, because while there's talk of it possibly not being as severe in terms of symptoms, one of the things that exponential maths always gets you with is that more mild but more transmittable ends up potentially with more people suffering, which I don't think is widely realized. So people should be very, very, very careful in terms of ensuring they have a safe Christmas and their family and friends stay safe. So community testing has never been as important. It's important that people report it because it helps track where viruses and things are moving. And again, I just want to thank all our volunteers. I want to especially thank Alice for all her hard work and Michelle's hard work and Nathan on this, and the board as well. You know, you've all contributed. And what we've started to learn is that there is a huge swathe of pockets of communities who are left out, unheard, not listened to. And you get such a positive response if you turn up and talk to them, are interested in them. And I think the other thing I'd just like to thank Public Health for is they have actually asked us to capture not just information about testing and things like this, but we're actually talking to people about, well, what other issues are you facing? So at the Soup Kitchen, you know, we've faced things like sanction from DWP, issues with accessing mental health, housing, domestic violence has brought up. So one of the really positive things of the community testing project is we are being asked to capture this and also to see if we can pass on or signpost people to actually get some action for change. Because especially in the harder to reach communities, small changes have huge, huge effects. So hence, you know, managing to get down to places like the mosque, the Soup Kitchen, and we were getting people vaccinated and tested, and they wouldn't have been. They simply just wouldn't have been. So very, very pleased with the team who've worked on it. And actually, interestingly enough, we're the only Healthwatch in the country who are doing this. So I think it's really telling that Public Health here have realized that in terms of community engagement, actually using an asset that you've got, it makes a lot of sense. So I know that DHSC and Healthwatch England are keeping their eyes on it as well, but really helps prove the concept and worth of Healthwatch as an organization, that, you know, we can take some of the things that are day-to-day work and do some practical stuff. So I think community testing, you know, keep testing, keep looking out. We're in the Kennet Centre all week. We're in Sainsbury's Calcott on Thursday. We're at Tesco's next week as well. If you need any LFT kits, head on down there. If you need help with testing, please tell everyone, you know, keep testing. It's really important, and not just when you're mixing, and hopefully everyone will stay safe. So that's all I want to say on that, Mike. Anyone got any questions on that? Oh, Adrian, sorry.
Yeah, thanks. The feedback that Public Health asked for, I don't know whether that's going back item case by case, or whether you're going to do some sort of collated summary. But if it's the latter, it'd be quite useful to look at that and give us a bit more of a picture of, you know, what some of the issues are in the community.
It's currently going back on a mostly thematic basis, but we've actually got individual action points that we can follow up. So if we've got people who need instant help, so it's been great that we've been able to connect them up with adult social care, or, as I said, the DWP, or help like this. So I think it really shows, as I said, these connections that we've got embedded. You can take a problem, pick it up, and help, hopefully signpost the person to get help, or in fact ensure that they are sent to the right person and are not just left. You know, one of the cases I mentioned, it had been floating around for 18 months and someone bouncing from one place to another, to another, to another. And this is what the system's got to get better at, especially with the long-term plan, talking about prevention and further upstream help. We have to get better at stopping problems getting worse and developing. Karen?
Do we know, Hilary Cole is expounding that we don't have any homeless now. Do we know how that has been managed, the last two entrenched?
I don't know the exact details, but my understanding, and the audit changes daily, is that currently we don't have any involuntary rough sleepers at all.
No. Do we know how that's been managed?
What do you mean? Because aren't you on the homelessness strategy group, Karen? Sorry, excuse me, I'm butting in. Well, I am. Do you want me to comment on that?
Yes, please. I would.
Andrew?
Please don't mention any names.
Names? No, I'm not going to mention any names. Just in general terms, there are no rough sleepers at the moment. And the way that's been managed, there's been government subsidies, you know, everybody in, there's Housing First, there's lots of new initiatives because of COVID. So, you know, COVID, the fact that Healthwatch raised the profile of homelessness, I think is significant, has meant that everybody has been working together in one group. The volunteers and the council officers in particular have been getting together to basically to combat this. And there is extra government money continuing to make sure that this continues. So that there has been some very good work with individuals to make sure this happens, because as people understand, some people have become entrenched rough sleepers, and so they've had intense work through extra funding for outreach work. So it is government money, but it should have come sooner, one could say, but it's happening now. And one hopes that the work that's been done will make sure that these people don't go back on the streets. So they're being supported in the new accommodation. So I don't know whether that helps, but I can get some, you know, I can get more information, obviously not naming individuals, but there is a lot of work that has been done.
I'd just be interested to know whether they're in temporary accommodation or whether they're in permanent accommodation.
Well, there are some still in temporary, if you count Two Saints as temporary.
Okay.
But the idea is to move them into their own accommodation. So there are a substantial still in Two Saints, which is being managed, and you know the previous problems have been addressed. Some of it is temporary, yes.
Thank you, Martha. It isn't really part of this item, so if there is anything further, perhaps we could address it in any other business. And I would like now to, for those who've got an agenda in front of them, actually move back one pace, because we have missed the Great Western Report, which I think Alice was going to lead on. Or is it you, Andrew?
No, Alice can talk it through. I must admit it's missing from my agenda as well and should be there.
Can you all hear me? Oh, I think Amanda wanted to say something before me. Amanda.
Just really to reinforce Adrian's point that if we are getting themes through from the vulnerable side of things in terms of all the work Healthwatch is doing, it would be good if we could, at least on the theme side, right, there's definitely no named people, circulate that and think about how we can get that perhaps raised and therefore sustainably managed, rather than use the themes to show how the system itself needs to have an infrastructure that allows the vulnerable people to be assessed, whether that's through commissioning Healthwatch to do it formally or somewhere else. So I just reinforcing really Adrian's point about what the themes were.
Thank you.
Thank you, Amanda. Alice, over to you.
Okay, thank you. As you all know that we were 2 years ago, we started this conversation about the Great Western Entrant View. Well, finally, the Great Western Entrant View report was launched last week on the 14th. And it was a joint press release with Healthwatch Wiltshire and Swindon. And the report was well received by the Great Western management team, as they acknowledged the work by giving a response in the report. So I have shared with you all the final report. And so you've seen that they've been very positive about the Healthwatch involvement. For them, Healthwatch has provided with a different perspective, which will help to re-examine some of the thinking and looking at how improvements are made in different ways. This report will be used to address improvements and implementation as part of the Great Care campaign, which is focusing on the 4 areas, which is delivering patient-centered care, care to reduce harm, the environment, and expert care. So it was a really positive report. And so I do think this is a good report, and it's a best practice to be looked as a best practice. Thank you.
Thank you, Alice. That sounds quite promising in terms of the response from GWH. And of course, it shows the working together of several local health watches. Andrew, I think you've got a...
Yeah, I think the other thing, I obviously want to thank Alice for all the work on this, but I think the other thing that is pertinent to this is this was the first interim review of its kind where we used virtual visiting with iPads and patients in Great Western. We rang patients who'd just been discharged, and there was a little bit of face-to-face because this was over a period where we thought we were coming out of lockdown and very quickly went back in. So it's a really interesting model that rather than just turn up on the day and capture whoever you speak to, the fact that we were able to talk to patients actually who were getting the care there and then, patients had just been discharged, and people right in front of us, I thought was really quite interesting. And I think it probably makes the whole thing a bit richer. And as you said, Mike, I think the ability to work outside of our ICS border, which Great Western is, and again, it feeds back into the conversation we were talking about earlier about how the system changing is going to affect our residents. A lot of people from West Berkshire use Great Western, certainly from the west of the county, from sort of Hungerford onwards, and wouldn't dream probably of going anywhere else. So we're delighted that we have this relationship with their management team, who I think should be applauded because the hospital has had some tough times, but they always seem very open to listening to constructive criticism. So were it thus for all NHS organisations listening to constructive criticism. Anyway, that's all I wanted to say, but well done.
Thank you, Andrew, and thank you, Alice. And the next item on the agenda is the Bhft project, which I think is Alice and Leslie, one other or both to lead.
I think, Alice, you could probably say the most about this. I helped out just by doing a few telephone calls. I think I just really had one thing to say about this, and that is that because all 3 health watches did it together, it was Berkshire West, I personally would have felt that it would have been better if we had met together on Zoom, sorted out the questions together, decided, how much free text we were going to use, etc., followed the same model. I felt it was a bit disjointed because we didn't actually work directly. Well, I didn't. Alice, you might have had more conversations with them than I did, but that's kind of the way I was expecting it to happen, that we worked closely together to formulate the model that we were going to use and then all follow that same model. And then you have one report rather than having kind of 3 somewhat different reports. But it was a really interesting piece of work and tremendously difficult to phone up people who are so vulnerable and elderly and have multiple problems, and you're asking them very specific questions, which is what we were asked to ask them about the care that they got, sometimes several weeks, on occasion a month or so ago. You know, there was a lot of, well, I don't really remember. Well, I think everybody did a great job. I'm sure everybody was fabulous. It was a bit kind of, well, this is almost impossible to ask some of these questions from people. So it was very difficult, but worthwhile, I think, anyway. So that's what I have to say.
Leslie. Alice, do you wish to add?
Yeah, I think there's a lot of lessons learned here, to be honest. But also we've had lots of feedback that we could improve the service. And I think Andrew has taken the report to BHFT. I think Andrew could say a little bit more.
So the report is currently with BHFT and it's going to the ICS board as well. I mean, one of the things that has worked really, really well was with a lot of hard work on the information governance side. We were able to actually speak to patients who didn't approach us directly. We were once we got all the online security in place, able to actually talk directly to patients, and the model proves the concept really well of being able to be connected via the actual NHS provider. And BHFT need a huge amount of credit in being brave enough to let independent organisations like Healthwatch, West Berks, Reading and Wokingham speak directly in an unfettered way to their patients. So while not perfect in its execution and what have you, I think it's a really interesting model, and going forward is something that I would encourage lots of provider organisations to take a really good look at, and being able to benchmark across Berkshire West, I think could be the way forward, and I suppose equally across the Bucks, Oxon, Berkshire West ICS framework going forward. So it's interesting that as a relatively small report, it's going all the way up to the top of the ICS management boards to be looked at. And I think, you know, some of the stuff Leslie was talking about was really key, that we had some desperately ill people who'd avoided hospital because of the service. So we're obviously very grateful of this. But one of the concerns about services like this is that what happens when the help ends. So the help is always gratefully received and does an amazing job, but then it tends to just stop in sort of cliff edge manner. And I'm not convinced that they've entirely ironed out the next steps. So it feels quite staccato in terms of its interventions, but perhaps we'll see this discussed when the report finally comes out early next year.
Thank you, Andrew. Right, we move on to item 8, which is the Contact and Issues Report, Thinking Together 5 and CAMS. Andrew, would you like to start on that?
Yeah, I think I'd start with CAMS actually, because this was probably the most significant piece of work we published, and what was rather fabulous was the Health and Wellbeing Board and the Health Scrutiny Board both had it formally presented to them, and I think there was an appropriate level of worry that if you read the report, this is really not good stuff. And two things sort of struck me. One, that no one felt they should be surprised by it. And that two, well, lots of things are happening that are going to change mental health for young people, and all will be well, but no mention of what about the people who are already in the system. And Leslie and Michelle presented the report to the Health and Wellbeing Board, and I think in a brilliant way that made people listen. So Leslie, can I hand over to you about CAMS and where we think it's going to go with the meetings we've had with the ICS?
Yeah, I mean, it was really I was really grateful that there was such a positive response from the Health and Wellbeing Board. I kind of did expect that there would be negativity because it's there's a lot of negative findings in the report. But I chose to present it in such a way as to keep it as positive as possible and to acknowledge the work that they are doing already, that the Health and Wellbeing Board is doing, that the transformation plan that is being republished, etc., and updated. And so it actually fit. It fit very well with everything else that was going on. And because we had a meeting prior to it with Nikki, what's her last name? Cartwright, is it?
Cartwright.
Yeah, Nikki Cartwright, commissioning lead. She was very keen to say, we need to think about what are we going to do for the people, as Andrew said, that are in the system now, that are having problems now. We totally agree with everything that's in the transformation plan, but a lot of that work is in the future. It's like what's going to happen in 6 months, and also a lot of it was very process oriented. Oh, let's change the way we're going to do this, and let's do it this slightly differently. But it was all very much in the future. So we focus very much at the Health and Wellbeing Board on what can we do now, what can everybody do, and there was a very positive response, I felt, from most people really. From the voluntary sector lead, he was quite keen, let's get around the table, let's see what we can actually do to make a difference. And I think from what we can do as Healthwatch is that we have the 128 names of people already who have responded and filled out that survey, and we can approach them again and others to actually become part of a group, part of a forum where they help in terms of saying what their ideas are for how things can be improved. And I think that we should try and do that, really, set up some kind of forum. I think that seemed to be a positive, practical step that we could actually take as Healthwatch.
Thank you, Leslie, and thank you very much for all the work you've put in. I do remain slightly, not quite sure what the word I want to use is, not certain of where all these resources are going to come from.
There is that, yeah.
Especially in light of the government's view that they would reduce contact time to whatever it was, 2 weeks and so on. And yet we know that certainly is a mile away from happening, and I just wonder where the resources are going to come from. But anyway, thank you very much for the work you've done.
Okay.
Martha has her hand up.
Yes, I'd just like to thank Leslie and Michelle for the report, which is an absolutely excellent report, and just so having looked at all the other reports from the Health and Wellbeing Board, it was really like a breath of fresh air because it was so simple, easy to read. And also the fact that it dealt with real experiences, I think, was really, really crucial. And on that particular meeting, there was the Joint Health and Wellbeing Strategy with all its priorities, and young people's mental health is up there quite high. But so I think, we need to make sure that this is constantly being revisited, and it's just not a lot of warm, supportive words, and it sort of drifts off into the ether. So I think Leslie's suggestion of using the people that have contributed to monitor and push and ask questions, and you said you do this and you said you do that, it's just such an important issue that we just have to keep on and on. And the preventative work, which was within the sort of things that the council can do now, is to make sure that all of the practitioners, its health visitors, social workers, are really aware of what to look out for and how to support people, where to refer them on, make the most of what you've got, reintroduce, have stronger hubs where parents can go, where they can actually get support they need. So all these issues are picked up and the support is given at a really early stage, so we don't get young people being missed as they have been in the past. Thank you.
Thank you, Martha. Adrian?
Yeah, I just wanted to congratulate Leslie and Michelle as well for the presentation. I thought it went really well at the board, and I thought it was good. What struck me at the time was this was Healthwatch making a difference and sort of getting the balance right of being critical and pointing out where things are wrong, but getting the various authorities on side and prepared to see the way we were looking at it. So well done.
Thank you, Adrian. Thinking together, Andrew, are you?
Yeah, so we finally put the report out for Thinking Together 5, but actually what they should probably do is kind of also say stroke Thinking Together 6. We were hoping to get an event done in November, but through various other COVID related issues, that isn't going to happen. But the Mental Health Action Group have asked us to very much make sure that something happens before the end of the first quarter in relation to both Thinking Together as an event, but actually specifically about, and it follows on from CAMS, young people and mental health. And our current plan is potentially to do 2 events as close together as we possibly can. One which would be for the parents and carers to actually discuss implications and what's working, what isn't working, why it isn't working, in the sort of classic Thinking Together way of, we're not just here to shout and scream, we are actually here to try and actually work through what works and what doesn't. And then also to actually work with potentially Berkshire Youth and some other organisations to actually get the young people themselves together to actually say, what's your take? What do you think should happen? What do you think should change? So that's very much on the cards, and hopefully all these pieces of work, there's a strand that starts to work through from CAMS, from the Joint Health and Wellbeing Strategy, putting children's mental health at the forefront, the ICS talking about prevention and its importance. So there seems to be some threads here that are crossing, and I'm hoping what we can do with a Thinking Together event, which may be virtual, hopefully not, but may not, that we can actually start to action some real change. And I'm hoping that certainly the response we got from Nikki Cartwright was really, really positive. So while the response from the Mental Health Board that we took the report to wasn't great, I think the response we got from senior NHS management was much, much better. So I'm quite positive about this, and I think we need to re-energize Thinking Together. We haven't really done too much in the sphere of young people and children, so I think this is the perfect time for us to sort of pick up on that, and also to take all the traditional supporters of Thinking Together with them as well. So this is not about excluding people, it's about being more inclusive, perhaps creating some new forums to take the commissioners and providers to listen to the actual people and hear what they've actually got to say. Back to you, Mike. Julie has joined us as well.
Oh, well, very welcome, Julie. And Amanda, you have your hand up.
Hi, thank you. Sorry, I had to come in late because I had another meeting at 12. I wasn't sure I was going to be on this meeting now, so apologies for coming in late, but it's very nice to meet you. I'm Julie. Thanks for having me on board.
You are now a member of the board.
Thank you very much. Really honored. Hopefully
you.
I can introduce myself and know more about you as well. I don't want to interrupt so far. I'm just be listening in, unless I'm asked. Thank you.
No, welcome, Julie. And regarding the last 2 items, you've mentioned Nikki Cartwright, and I just wanted to check, is she somebody who's going to be sustainably involved in mental health beyond April 22? And if not, maybe we should get something written down somewhere that kind of makes sure that it's going to be sustainably taken forward if the sort of infrastructure changes a bit below ICS level.
And yeah, we'll pick this up at item 10 again, Amanda, but honestly, she seems to be one of the more long-term ICS members of staff, she's very well thought of, and I think what's been really positive for us is she is very, very interested in the work that we do. She's very interested to hear in a way that we haven't often seen from senior management in the past.
No.
So I think, you know, and Leslie will attest to this, that, you know, this was not one of the classic NHS, you know, whatever you say, I will refute it. It was, yeah, okay, but we've hopefully put mitigations in the way, but how can we equally together go and actually improve things? So I thought it was so very refreshing. So I am really hoping if the ICS has got anything about it, it keeps her on board.
Okay, thank you, and well done on both pieces of work. Yeah.
Thank you, Andrew. We now move on to item 9.
I can see that Kev's got his hand up.
I'm sorry, but I'm not taking any questions from members of the public until the relevant spot. Item 9. The first item is the waiting time survey, which I think you're going to lead on, Alice.
I think that's probably me.
Oh,
sorry.
It's okay, Andrew, sorry.
Sorry, no, this was taken from a Healthwatch England piece where every Healthwatch in the country was trying to look at the imminent tsunami of waiting times that was obviously going on. So we've amended the Healthwatch England survey, and again, it's been done across Buckinghamshire, Oxfordshire, and Berkshire West. Sadly, we didn't get a brilliant response to it. So I think there's about 350 responses across, which is so super disappointing. If you think we got 128 for just CAMS in West Berks, so to get 350 out of 2 million as a population was pretty poor. But I think the problem, I would never obviously like to criticise our governing body nationally, but it did feel a little bit late and a little bit like we were just jumping on a bandwagon. We haven't seen an awful lot of kickback from the public in terms of waiting times. It feels like this is a media generated thing. People are absolutely clear why they're happening. They're not happy with it, but there is I think quite a good understanding in the public of what's caused it. Obviously, it's great that there are plans in place to try and mitigate it as fast as possible, and we should be doing this. But I think the public are very stoic about how they realise we cannot just magic up medics and consultants and nurses to deal with a once in 100-year event and all the additional pressures that the pandemic's put through. So we will hopefully be publishing that imminently. And that's all I really want to say on the waiting time survey.
Thank you very much. And the carers survey?
And just to say again, our response has been poor, but we are still continuing on with it.
I think we might need to reassess it though.
Yeah.
I'm afraid. I think it's a piece of work that hasn't worked, and I think we need to look at it from scratch and see why not, because I cannot believe it is not an issue locally.
Indeed. Fine, well, we'll reassess that. Alice, what I assume you're going to talk about the Diversity Forum?
Yeah, just to share that we had a meeting with the Diversity Forum 2 weeks ago, and we spoke to the community leaders, and it was very responsive. And we had a very good response, and the community links were sharing. So we had Dr. Deepak Ravindran there talking about the long COVID service, and also we heard from the community. And one of the feedback was about trying to get appointments. Going through the receptionist was quite hard. The other one was a request from the South Indian community saying that they are happy to find a venue, bring the community, and if they can bring the vaccine van to them, which we were in the process of doing it when all the changes took place. However, 40 of the members from the South Indian community were vaccinated within an hour when we called them. So that was a real good response. So there was no hesitancy from them to have the vaccine.
Oh, good. Thank
Andrew,
you.
might say?
I'm sorry?
Andrew was there, so he might want to say something.
Yeah, I think again, this comes back to what we've been talking about, which we'll get to about the ICS and the whole point of prevention, targeting health inequalities and health iniquities, which is my preferred term. The Diversity Forum has basically proven that you can get to people, you just have to do it in the right terms. You know, there's a term that I try desperately not to use, which is hard to reach. No one is hard to reach. You're doing it wrong. They're not hard to reach. You're just not listening, or not listening in an appropriate way. So we need to change things like that. You know, just the terminology is really insulting. But I think there is a real urgency in the NHS, and I've seen some sign of it in the new ICS system, that they realize that if we're going to really transform the NHS, we have to stop people becoming sicker or iller faster and quicker, and not just waiting till they've ended up in A&E or, you know, in level 3 or 4 with mental health issues. We've got to get people before then. So yeah, the Diversity Forum has thrown up some fabulous examples of how and when things could be done differently. And what we have to somehow do is make the commissioners and providers come and listen, do so appropriately, and alter their actions. And incredibly disappointingly, in my humble opinion, the mobile vaccination van was stood down so that the staff could be repurposed to do other parts of the vaccination program. And yet its very ethos was to be able to vaccinate those communities who perhaps are being left behind in small numbers. So again, we've gone from a really targeted service for a really particular reason, you know, and the fact that we took the van down to the mosque, to Newbury Soup Kitchen, to 8 Bells, to the Phoenix Centre, you know, exactly where you'd want to see it. And then we potentially get offered 2 and 3 communities who are prepared in numbers to come and get vaccinated, and it gets stood down. So that was pretty disappointing. But I think the Diversity Forum should be supported universally. I like the fact that it's got a real breadth of informal members. It discusses all sorts of interesting things, and I think West Berkshire should be delighted it's got one, and it always should have had one. But we still need to build on this. It's paper thin, and it needs some resource and support from significant statutory bodies, in my humble opinion.
Is it growing? Or is it the same small number of?
It's still a relatively small number, but what it is really significant people. And I think that is often the key to this. This is not, you know, I think too much of health is this numbers game, where show me a huge number and you know, I'm happy. Because that's currently why we have such massive health inequality, because we settle for the 9 out of 10 and fail to notice that the 1 out of 10 is always the same people who are let down in 5 different ways. So let's be a bit smarter. And I think, you know, let's not make this mistake of just going, well, how big is it and how many people turned up? You know, it's who are they? Are they significant? And are they taking a message back that's cascading out? And I think, you know, thanks to Alice with both her hats on and Community United, we really do have something here, and we're doing things that lots of other places struggle to do. Public health have struggled to do this. And again, it sort of underlines the connections we have. And if you use them in an interesting and an innovative way, you get really good results. So hence the community being vaccinated en masse. We could have repeated that. We could repeat this anytime we can get vaccinators and vaccine, but we can't, which is a really disappointing thing.
Yeah.
Mike, just to share with you that the community only had an hour's notice and they came.
Wow.
Within an hour, 40 people got vaccinated. They only had an hour's notice.
Well, that's excellent, isn't it?
Yeah. So they proved that they will come.
Yes.
If you call, and the right people were informed, and they did come. So it did happen. If not, that vaccination program would have failed that day.
Yes, yes. I mean, obviously there are complications given the vaccine that's used and the number available, which wouldn't be the case if we had a slightly more simple vaccine, but that is life. But it's good to see that where circumstances are right, communities are coming forward to be vaccinated. And sad that, as Andrew has said, the mobile ban has effectively been taken off the streets, as it were. Fine. Okay, thank you. Alice, I think you are probably going to talk about the maternity forum. Or is that Leslie, you?
I mean, the maternity forum hasn't gone forward at the moment, but we are very involved in the vaccination side of it. So we are trying to help to get more pregnant women vaccinated. So we've been involved in that one at the moment. I think a lot of our maternity side of it has sort of gone to the vaccination and community testing.
Okay, fine. Thank you very much. Volunteer update and social media.
With the volunteer update, we've had 5 more new people come and volunteer for us, which is very good, which has been really positive. And one of them is someone who's very interested in looking at the Healthwatch youth. So in the new year, we're going to be looking a little bit more, we're going to be doing a lot more work with the Healthwatch, about Healthwatch youth. So it's really, really positive. And our social media, I'm sure it's increasing because a lot of people are looking at information that we share about the community testing and also about the vaccination. So because every day we are sharing new and the information that needs to be informed to the community. So like the vaccination center times, about Hungerford. So, you know, our social media has been really, really strong.
Okay, thank you. Right, we move on, I think, to item 10, which is the STP/ICS update. Andrew?
Let me just quickly do the headlines. So we have both a new chair of the integrated care system, and if I do apologize if I get this wrong, I think it's Javed Khan.
Correct.
Now he is a chap who's got a pretty remarkable CV. I think he was chief exec of Bernardo's, is seemingly well thought of, well connected, and clearly, you know, a positive appointment. But we haven't had a chance to meet with him yet. But we've effectively planted a flag in the sand to say, can we do this as quickly as possible? But he doesn't start till I think April the 1st. The other major piece of news that will probably come as no shock to anybody was Dr. James Kent managed to retain his position as chief officer of the whole shooting match, having been made to reapply. I think, you know, the disappointing thing for us was that while this process was going on, the whole system just stopped engaging, which is you know, and I've mentioned my concerns with the whole way this reorganization is going, and the fact they have a major engagement piece to write of how they're going to do it that has to be in by April. And, you know, I'm afraid, you know, on past track record, they really are nowhere with how they do this. You know, you cannot stop engagement just because, you know, an internal recruitment process goes on. But that's what's happened. I've mentioned in a number of meetings about COVID and things response where we're challenged with workforce challenges because we do have a shortage of all sorts of qualified clinicians. We, however, do not have a shortage of marketing professionals in this country and communication professionals, but the NHS singularly refuses to employ any additional ones to actually tell the public what it's doing, why they need to alter their behaviour, where they should be going. And it really does seem to be a real shock when you actually point out how are the public meant to know this. You know, self-care, really, really important going through, you know, people taking care of themselves, doing as much themselves without necessarily pressurising the system. But it hasn't been explained when and if, and this is why you get these panicky communications going, no, do come to the GP, or don't go to the GP, or see the practice nurse, or see the associate physician, or the community pharmacist. No one's had time to actually tell the public what all these roles are, how they fit in. And then, as I said, and if anyone goes to Parkway, it was still up last time I was there, on floor 2, there is still a poster saying, go to your GP for your over 40s health check, in a great big poster. And that's about the last thing GPs need at the moment, is a pile of 40 pluses going, I'd like my health check, please. So this lack of understanding of the importance of communication and talking to the public and listening to the public is a real concern. So we now have a chief exec, we have a chair. They now have to appoint everybody, it would appear, but obviously an awful lot of people are going to swap from what the clinical commissioning group is to various parts of this new ICS and ICP system. So I don't think the plan is to get rid of everybody and then, you know, get whiz kids in from KPMG to do all their jobs, but you never know. But the concern is in constructing all these new things. They have to do it at huge speed. Healthwatch is mentioned 2 or 3 times in the actual health bill. We have been promised places on the place partnership board. I'm not sure about the ICP board, and we haven't been offered a place on the ICS main board, which is hugely disappointing because Healthwatch England has modelled systems like Leeds, where they have gone for the minimum number of members and are recruiting non-exec directs, 2 non-exec directs who are meant to understand patients from across Buckinghamshire, Oxfordshire and Berkshire West, be able to keep abreast of everything going on. Just don't really see how they can do it without an enormous amount of support, or finding people who understand the system. And remember, it's not just physical health, it's mental health, it's children's health, it's prevention. It's, you know, short of actually getting someone who's actually headed up an ICS, I don't know who they're planning to appoint. The other big concern, of course, is again, the system feels a long way away from the Kintbury's of this world and places like this, where they'll be relying on health services from outside of the system. And the minute you do this, it seems to cause all sorts of problems. So, yeah, I'd love to be more positive about all this, but there's a constitution being put together at breakneck speed with little involvement of the public, little involvement of Healthwatch, little involvement of local authority, key partners. So I don't see how this transformative system is going to be transformative by excluding people. Amanda, I'm glad you put your hand up, because I wanted your view on all of this and see if you've got any wisdom or knowledge that the rest of us don't.
No, and I'm sorry I haven't been able to chat recently with you about it, but I guess, you know, it's good that we've got the chair and the chief exec confirmed now. And I was actually just, I guess I was going to ask a question on a point of clarity, but I'll come back to that. I mean, I do think that as Healthwatch West Berkshire, we should probably think about the areas that we are active in and map it to the level of granularity in the ICS that is relevant. So, for example, is it at the provider collaborative network level that we need to map things across? Or is it at the primary care network, if it's a sort of more GP-led, practice-led sort of service, so that we at least know as Berkshire West where the key points of decision making are going to take place, because I don't think everything is going to take place at the ICS level. And then I guess the other thing I was going to say was I wasn't quite clear, because you mentioned leads. I wasn't quite sure whether you were saying, it sounds like Healthwatch has not got a place on the board of the ICS of Bob. Are you saying in Leeds they have?
I believe they have. I mean, when we say we're asking for a place, it's not a place for us, but it's a collective place for the 5 health watches. Yeah. And in the Leeds system, they've exactly said, well, imagine a patient, an organisation that spends its life talking to patients, has the expertise on the ground. You know, my view is, why wouldn't you want that collective, non-voting, independent voice on your board? Because my concern is, with our board, you are putting an awful lot of store in 2 non-exec directors to stand up to or challenge or whatever, and that's a heck of a job when you're the one person in the room who has to go find the information, find the justification, find the evidence to potentially suggest that things maybe could be tweaked or altered. You know, there's this sort of assurance up the chain, where once a report gets assured by one board, it gets assured by another, it gets assured by another, and it's rubber stamped. And if this system was working, we would not have one maternity scandal followed by another, followed by another, followed by another. You know, there is no evidence that there is learning going on. There are reports being written, and you know, to have a board who potentially could follow that process of, well, we're assured and they're assured and they've said, and therefore we're going to do it, with no granular feedback from the actual coalface, is a real concern, I think.
No, so it does sound like the whole kind of patient voice assurance is missing. And is it too late for us to, as Berkshire West, but also across Bob, raise this as an issue to the ICS and say that there needs to be a clearer accountability to the public at a local and across the ICS body level, in order to ensure that this is not left to, like you say, the chairs to do that alongside everything else. So I mean,
I think so. And I thought it was really interesting, Martha's point earlier, when she was saying, you know, we should be talking about getting the public involved and what have you, and
being more public about the fact that they're not.
Yeah, and because I think the thing that worries me is that we're going to end up with a system set in concrete, and then they're going to say, what do you think of this?
Yeah.
If they even say that.
But I still think it's relevant for us as a Berkshire West to be looking at where decisions are being made about us, because they won't make every decision at the ICS level. There will be some things that are rubber stamped at the ICS level, where actually the proper discussion is taking place at a lower level. Because you just can't make every decision at the ICS level. They can look at themes and things like that at a bigger level and look at the overall kind of balance of resources. But for the day-to-day issues around patients who live in West Berkshire, I think we should always know, whenever we've got an agenda item, what level of granularity of system is that working into? Because they are almost, they're not statutory bodies, but the provider, you know, I see the provider collaborative networks being really important for things that are happening at a hospital level, and then for things that are happening at a kind of more community level, then it's more the kind of, I'm not so familiar with that, probably the primary care network level.
Yeah, I think that's a really good point.
To match all of these. But I think if we pick out the key ones, then we can make sure we're also trying to have a voice on those.
I think you make an excellent point, Amanda, and I think what we might need to do as a board is ensure that's what we're doing. So you almost think in terms of our action log, if we've done a report or something like this, we need to actually start asking ourselves, who needs to see this and who do we need to talk to about it? Is it James Kent, or is it in fact, someone in the provider collaborative? Because it should be the ICB board rarely. It should be the really big stuff. So if we were talking about CAMS 18 months ago, or rough sleepers 2-3 years ago, that probably should go to them to say there's a major issue with how rough sleepers register for primary care and things like that. So I think you're absolutely right. And you've probably certainly helped me sort of work through, because practically every time we ask a question, we get told it's changed. So it is genuinely like dealing with shifting sandbanks at the moment in terms, so we haven't got anything firm, but now we at least know the chair and the chief exec, and hopefully it will start to very quickly populate, and we just, as you said, need to be in the right place at the right time. Martha, you've got your hand up.
I was just going back to what I sort of touched on earlier, just to see whether, it's a shame we didn't have the opportunity to possibly discuss this at the Health and Wellbeing Board, where you've got a partnership of people that maybe can be hopefully working together. Healthwatch is like the sort of troubleshooter, as it were, identifies what's going on and says, come on, what are we doing about this? But then works with the partners to make sure the public is aware, to basically show that this is something that it's not, that other people out there are concerned with, that the community leaders are concerned about, but they can't be concerned about it if they don't understand what's going on. So I'm just wondering whether Healthwatch has a role to possibly get out there and inform, maybe, I don't know. I'm just thinking of how we've just had a Health and Wellbeing Board, but whether there's a role for something at one of the council meetings or a report to.
Well, I think it's really interesting, Martha, that this was on the agenda and it got bounced due to lack of time.
Yeah. Well, exactly.
And I think that in itself says everything you need to know, that the most important change in health in however many years doesn't get discussed because it's not deemed important enough. Whereas actually probably what they should have been doing is having a special meeting about this.
I couldn't agree more.
But,
and it's often not discussed enough because not enough people know enough about it to basically discuss it. Do you know what I mean? You've got to know what you're talking about. We had Jo Reeves there, but I don't, obviously she's there to answer questions, not to sort of basically challenge things, really. It was a difficult meeting because of COVID, with very few people in the room, most people, on the screen. I think there's lots of issues. I think I raised, the issue about the new hospitals coming up. There's a dearth of information about that. So you almost need a special meeting about ICS. I don't know, maybe 2 special meetings. I think health is crucially important. Everybody's concerned about health, so it should be much more out there and high up in everybody's agenda. But anyway, we can sort of have a think about this but it's.
And just to kind of follow up, I do think if it was bumped from the Health and Wellbeing Board agenda and we have this concern, then maybe we could ask for an extraordinary meeting in Q1 on it, just to say that we feel that the public accountability isn't that clear, and we'd like to particularly discuss that and understand. And also maybe request maybe clarity of the provider collaboratives and things like that, because they should all beginning to be formed. You should be quite clear about those structurally, even if you haven't got the people.
Amanda, there was a question in the chat. Did you just want to quickly tell everyone what the provider collaborative is, or what your understanding
is? Oh yeah, sorry,
is?
I didn't see it. Yeah, so basically, part of the whole kind of bill that's going through Parliament is that you've got the formation of these ICSs, but actually they are very, very large, and therefore within those there is more ability for there to be kind of alliances across certain groups. So for the provider collaboratives, which I think are quite important, that's where hospitals are going to be able to club together and manage the care pathway across hospitals. And actually the funding flow should be not disincentivizing that. So historically, you've got one hospital trying to kind of get, because they're paid through payment by results, get all the money coming to Reading, let's say, whereas they could go into a sort of collaborative with others. And I think there will be these provider collaboratives, and I'm not actually that sure whether they're across hospitals as a whole or whether it's a provider collaborative on cancer care or on mental health care and things like that. So that's what a provider collaborative is. And then the kind of primary care networks are where actually the delivery of the service is much more through primary care than a hospital, and therefore those primary care networks are smaller and bring together the kind of whole primary care infrastructure, not just the GP surgeries, including retail pharmacy as well.
Andrew, thanks, Amanda. Andrew, do we have any information on the state of the contract of our ICS paid for liaison, Healthwatch liaison officer?
I'm afraid not, because the chief officer's post wasn't in place. The joint Healthwatch officer's post ends as of last week, so we now don't have one. So they're having to invite 5 Healthwatches to various meetings. And the real shame is that we were the first system in with a joint officer, and frankly found ourselves chasing a system that was talking to itself and trying to work out how it gelled. But what I do want to take out of all of this, because this is clearly quite important, is that we need some actions. And I wonder whether, Mike, we should be writing to Councillor Graham Bridgman and requesting an extraordinary meeting, writing to Dr. Kent requesting an extraordinary meeting, because unless you are an expert in this, and we seem to know quite a lot and we seem to be in the dark, what are the members of West Berkshire's population to think, to be told that all of a sudden this isn't happening, that CCGs don't exist, whatever they do? Primary care networks are being drowned in COVID vaccination targets. So I mean, obviously change and the unknown are always things that terrify most people, including me. But I think something that's so significant as what's happening just seems to be being done in a vacuum. And I am surprised that, members of the local authority don't seem more concerned. Perhaps they are. I don't know, but I wonder whether we need to take some actions. And I wonder whether initially it's perhaps writing to the chair of the Health and Wellbeing Board, the chair of the Health Scrutiny Board, perhaps the chair, the chief exec of West Berkshire Council, and saying,
it seems a reasonable way forward, I think.
I think the good thing is at least it's an action, and then they will then tell us why we do need it or why we don't need it. And I'm hoping that the ICS would be quite keen to, we shouldn't really be pushing their engagement strategy in terms of creating one, but we are, so let's do it, I think. I don't know if the board is in agreement with that.
Everybody agree? We have the answer there, Andrew. Right, well, thank you for that. And that brings us to I can find my agenda again. That brings us to the conclusion of the main part of the meeting. It is now time for any questions from members of the public stroke audience. So if you do have a question, could you please make sure you introduce yourself fully and any affiliation you may have, and please state any question you have clearly. So are there any questions? Any questions on anything you've heard? Or
Mr. Hood had a question previously. Oh, there he is.
I think Kev has put his hand up somewhere. I've lost him on my screen, but would you like to go ahead, Mr. Hood?
Hello there. Yes, my name's Kevin Hood. I'm chairman of Depression Expression and currently also in charge of mental health mates in Reading. I have a question regarding mental health intervention, most specifically with young people. I would like to know how I can more easily engage with CAMS to work with a project that I'm currently involved with Reading University students, their Community Champion project. They are very keen to work alongside me to get students to go into schools and talk of near lived experience of their time during school and address the problems that come directly from children. It seems an obvious way to me to get information to the younger people. I appreciate CAMS is incredibly busy and maybe they haven't got time for an organisation such as ourselves, but it seems strange that CAMS based up at Reading University site cannot engage with the leader of their Community Champion project on the campus. I would like to know how I can circumvent the system so that we can at least explore the possibility of getting this idea up and running within not just Reading, but in the whole of the West Berkshire area. Any suggestions on who I can contact and get a decent response from?
Andrew?
Hi, Kevin. Thank you so much for the question and thanks for coming along to the meeting. Hopefully you found it interesting. I think while I can throw out names at you, I actually think what might be more useful is if you get in touch with us offline and we go bang on the doors together. Because in terms of where we were going with Thinking Together 6, we currently don't have an agenda. We don't have any invited speakers or guests or anything like that. So we start with a blank sheet of paper. And if you think you should be on that blank sheet of paper, that seems very reasonable to me. We can make sure that we get CAMS representatives along to it. We can make sure we get young people along to it, or carers, folks from adult social care as well. And what really works with that is when people, I suppose, see that there's either a good idea or a good idea can be developed, and how, and the professionals especially like the fact, the professionals like the fact that good ideas or that come from the floor or come from organizations can be molded around their existing strategies and things to reinforce them in effect or amend them. I think that sounds like a good place for us to start. And, you know, we work with a range of voluntary organizations. We'd be delighted to work with you. And if you want, you know, if you're further ahead on some of this, you know, I love the sound of the idea of university students going back to school going, right, this is where it all goes wrong. Don't do this, do this, you know, or this is what happened to me, and let people, you know, take what they can from there, because we have this huge disconnect from the CAMS service to adult mental health services. You know, they are siloed. Absolutely, you get transitioned from one to the other. So yeah, I think let's talk offline and let's see what we can do. But do come back, Kevin.
there is the number 5 counselling service, which runs in Reading, which I'd like to see expanded elsewhere, which deals with people from 16 to 25 years old specifically. So they do pick up the people that get dropped off. And they're another organisation who are also massively overloaded, but I would love to engage with them too. Make it a 3-way thing.
Perfect. Leslie.
Yeah, I just wanted to mention the Emotional Health Academy. I don't know whether you've had any discussions with them, but it would seem to me that they do so much work in schools that that would be a good way in as well.
Okay, I'll look them up.
Thank you for your question, your input. Adrian, you've got a point on this?
Just very quickly, just to add, the equivalent of number 5 in Reading, their equivalent in West Berkshire is Time to Talk. They've got a website, t2t.org, I think it is.
Fine. Well, thank you for raising your question, Kevin. And if you come offline with Andrew, I'm sure we can take this forward. Sorry, Andrew.
Yeah, Kevin, if you go to our website, our contact details are on there, but it's basically contact@healthwatchwestberks.org.uk. Could someone put that in the chat for Kevin? That would be great. By the time I've typed it, the meeting will be over. Yeah, but no, do get in touch, Kevin, because I think again, we have a real opportunity here to start joining some things up. While we are Healthwatch West Berks, we do collectively work with Healthwatch Reading, with Healthwatch Wokingham. As you can see from this system that's gelling together over our heads, we should, in theory, have an excellent opportunity to actually focus some attention from commissioners and providers to perhaps start looking at things in a different way, or a more holistic and an interesting way. And as you said, that point about the 16 to 25-year-olds, you know, we found in our CAMS report that people virtually stopped worrying about CAMS because by the time the waiting list got through them, they weren't even in CAMS anymore. So we need to get rid of these cliff edges and make care holistic and follow the person, not the system. So I think there's some good stuff we can hopefully do there. Mike, I've got a piece of AOB just in case.
Okay. Are there any more questions from members of the public? I don't see any, so fine. Okay, we will move on to the next item, which is any other business. And I'll start with you, Andrew, as you.
Yeah, sorry, I thought it was on here, but I think it may have been accidentally taken off. Voice of Disability, we are slated to take a follow-up to it to the May 2022 Health and Wellbeing Board. And I think this needs to be really quite significant from us in terms of our efforts in the first half of the year. We were promised a golden thread of disability throughout every single piece of transformative strategy, and we've seen little sign of it. So again, with all these major systems forming and what have you, it would seem a perfect time to do it. While, you know, Paul is happy to lead on this, he needs as much help and support as we can possibly do. We're not sure whether we need to actually hold another Voice of Disability event, whether we need to just go through the recommendations and starkly report back. I think getting involved in the provider collaboratives where we're asking hospitals to do immediate audits on disability access and things like this, whether or not they rebuild the hospital, because that isn't going to happen for 5 years. So what happens in that 5 years? You know, everything about transformation is jam tomorrow. And what are the people who are in the system meant to do today? So yeah, let's ensure we give this the support and potentially remind statutory bodies that just because the Equality Act dropped the word disability, it doesn't mean disability was dropped from the Equality Act, which seems to have actually been an unfortunate consequence of the Equality Act, in theory improving and widening things. It seems possibly to have been a retrograde step for disability rights. Karen.
Yeah, a couple of things. Hilary Cole, I understand, is moving out of area, but still retaining her place on West Sparks. Is there a question that we should be asking about that?
Mike?
Sorry, is this in relation to the Voice of Disability, Karen, or is this a separate item?
This is separate.
Oh, sorry, have we finished with the Voice of Disability, Andrew? Or?
I thought we were under AOB.
We are. I'm not sure that Andrew's point.
Well, yeah. Thanks, Leslie, for offering to help. But I think, again, as an action point, let's see if we've got some letters to write or something like that. Karen, coming on to your point, I can't see how that sits with us particularly.
As a voice of the public, no?
Well, yes, but in what?
In relation to health, is it?
She can remain as an elected councillor, so she's not contravening anything. But she's not going to stand the next time around.
Okay.
But yeah, I can't imagine why we.
In terms of homelessness, I was thinking and things, which is our remit.
But yeah, but she's the executive appointed councillor, so that's we will always deal with whoever is placed in front of us, and providing they abide by the relevant rules.
Okay.
I don't think it's for us to decide the national government's wrong.
Okay, my second question is, did we ought to be asking, or could we be asking questions at the Health and Wellbeing Board? I mean, we could ask about VOD, voice disability, couldn't we? We could ask about what's happening. Where is disability?
Karen, we are. That's why it's scheduled for May 22.
But I mean, there are meetings before that, aren't there?
I know, but we've raised it at them. But what we've actually said is, what are you exactly this? So effectively, they've said, "We'll come back to us with something at this meeting. It will be presented as an agenda item." I absolutely agree that we have to re-energize the various committees underneath health and well-being. But I think the work's been done in terms of saying, okay, you know, we've discussed this once, but what's been done? They've now then said, well, come back and tell us what the problem is, or if there's a problem. So I think it's actually slightly still down to us.
We should be asking for statistics. We need to know that there's been some progress.
I think the general theme of the fact that it was meant to run through everything and clearly isn't, but what we're talking about doing is going through the report recommendation by recommendation and saying what's happened. So in a way it is, but I wonder whether there may be some merit in dropping in some questions, but it's which questions to ask and who's going to write them. And actually, I'd almost be encouraging disability groups to potentially do things with us. We once did this with the Learning Disability Partnership Board, where we put in a joint question, which I thought was really innovative. So perhaps if we're talking to Berkshire Vision or similar organizations, perhaps, but I think the disappointment for me is how little attention some of the voluntary sector organizations take of the Health and Wellbeing Board. I think they really miss a trick.
Well, I was amazed because I asked a question last week, whenever it was, and they couldn't give any idea of trends because they changed systems, which is certainly not good enough. You mean, so they couldn't give me any stats going back any further than before COVID, because they've changed systems, which we need to hold them accountable for any improvement in services.
Yeah, I mean, again, I suppose it's an interesting point is whether there has been any improvement in services. I think my concern is I don't think people read. I don't think people are
covering it up
looking.
by saying they couldn't, they weren't able to get any statistics, which is ridiculous.
Yeah, but I think the point I'm making is, I think we need to re-get Voice of Disability on. Yes, it is on the agenda, but I don't think it's in people's minds.
Okay, thank you, Andrew, and thank you, Karen, for that. Is it Adrian has his hand up?
Yeah, there was another item that I think was on the original agenda that fell off, which was the joint health and wellbeing strategy. I mean, I didn't want to say an awful lot about it, but just to say it was agreed at the last Health and Wellbeing Board, and there's quite a long list of actions coming out of it. There's 29 pages in the delivery plan across the 5 priorities. And I just wonder, I'm not quite sure how, but I just wonder if we ought to be trying to sort of keep a bit of an eye on that, mainly because I think there's a real risk, because it's such a long list, that it's treated item by item, that they get sort of feedback reports and exception reports, but don't ever see the big picture of how these things link together. I'm not sure how we can show how they link together, but I think that might be an ambition where we have a role as one of the very few bodies that has a responsibility across the whole of health and social care.
I'm always worried about things which have got long lists of recommendations, because as you say, I think unless there's some magic way for grouping them into themes or whatever, it's very easy to sort of pick little bits and say, oh yes, we'll do that, and the rest gets forgotten. But I'm sure we have a role in trying to do something. Martha?
Well, I think we were told at the meeting that each of those different sections, there'd be a sort of special report back just to keep track of what was going on. So there'd be a sort of like a concentration on a different section at future meetings. But yes, it's an enormous list, and it would be nice to know whether anything had been achieved from the previous long list, from the previous strategy. You just have one strategy, then you have another and another, and do you know what's been achieved from all this work, all these words? So I think there is a frustration. So I'm one with Karen here, that there should be lots of questions coming up and lots of irritation about what's really happening here, and show us what you're doing. And we've now got health scrutiny, which Andrew was involved in. So that's another vehicle to actually bring stuff forward, and it is chaired by by a member of the ruling group, but it is very much working on a scrutiny agenda, and it isn't afraid to scrutinise things that are coming forward on the council. So yeah, I mean, it seems rather cumbersome, health and wellbeing, and the strategy looks quite cumbersome. But I think maybe this issue of bringing sections back and looking at them in detail and looking at the progress sounds like a good one.
Thank you, Martha. Leslie?
Yeah, I just wondered, aren't there delivery groups or action groups relating to all of the major priorities in the strategy, which will actually be working to ensure that there is delivery of all these actions? Or is that not happening now?
Yeah, that's the intention. So things have been delegated. There's a question as to whether some of those groups are able to deliver on the actions they've been given, like the Mental Health Action Board, which doesn't have any executive authority or any resources, but that's a slightly different question. But I think my point was, I think the Health and Wellbeing Board will take reports back on what's being done, but I suspect it'll be rather sort of fragmented, and the bigger picture of how all those things work together to make a difference may be lost. But how we, it's not very easy question as to how you do bring it all together, but that would be the ideal.
Andrew, is your hand up?
Yeah, because I think it's kind of interesting here that you can probably do this in a fairly light touch way, and almost give a Healthwatch rating of a recommendation or a delivery groups and activities. That might be one way of considering it. Or alternatively, which would be really bold, you do take this holistic view. But I think the challenge is to take a holistic view. How do you decide what the view is? What data you're using to evidence that view? You know, because we have some very big challenges and targets here, and half the challenge is, well, how do you measure it? You know, what does success look like? How do you measure that you've achieved it? And also, you've got this terrible thing. It takes 5 years to work out that what you're doing has worked or hasn't worked. And I do not have an answer for that, but I'm just genuinely asking the question: what do we think? How could you approach that, or do you almost give them a score out of 10 in a sort of Strictly Come Dancing way, as to whether or not they're? Because remember, you've got what these massive wordy documents often do is they lose the public at the start, and they sit on dusty shelves and are looked at in 3 years' time, and then someone writes another one to sit on a dusty shelf. And I think that the hope, I think, with all of this was that we were actually going to get something that was going to do something, and you could point at and go, look, we built that pyramid or whatever it happens to be. But at least we did something. But this stuff is hard. I like the fact that the HSG and our homelessness report did set a snowball running down a mountain, and we can probably point to some benefits, and some of it was probably us. So while lots of work was done collectively by everybody, there was something that you could, and I think, Adrian, what we've got to think about is, how do we set that snowball running, and then how do we measure whether or not it's been successful? I think that's really difficult to do, but I think it would be a really interesting thing for us to do. And I think you're right in terms of our breadth of what we do probably puts us in a good position to do this, but I have no idea how we're going to do it.
Thank you, Andrew. Martha?
Well, just quickly, I mean, there has been a suggestion, well, it might mean not on this particular issue, from the council, that they want to conduct debates within the chamber. So not just, the day-to-day stuff, but themed debates, which is something we did. I asked them to do this some time ago. And I think issues around health, I think, are good ones to be debated. So maybe we could be putting Healthwatch, or someone puts, a sort of something forward to be debated within the council chamber. It is one way of, this is something the leader of the council in Doherty is supporting. So, that might be something that we're suggesting, just to sort of get something, get people interested.
Okay, thank you. Interesting. Leslie?
Yeah, just one other thing, Mike. Yeah, I totally agree with Martha. That's definitely, debates are really an excellent idea. But I also agree with Karen. We've got the Health and Wellbeing Board. You are able to take questions there. We should be taking questions every single time.
Yes.
Keep on asking the questions, because they have to respond to those questions.
Yes.
And that's what keeps it on the agenda, isn't it? So
yeah.
I agree, we should do that.
So I think the challenge there is to work out
what are the questions
prior. What are the questions? What are the topics? So can I ask the board during the Christmas holiday break to go away, write some questions down that they think they'd like to, and we'll start slotting them in. I mean, it's a real miss, and my point about other voluntary sector groups is that it gets recorded, it gets minuted, it gets responded to, and sometimes perhaps it does has that effect. Paula Sanderson's been incredibly effective.
She has
in answering questions about continuing healthcare, to the point that there was even a presentation about it. And you know, I am disappointed that some of the other voluntary groups just seem to ignore the Health and Wellbeing Board. And it might be because maybe that it's never been explained how important the damn thing is, or
why doesn't somebody write a letter to the paper?
Because only 12,000 people read the paper, Martha.
Well, it goes out online as well, doesn't it?
I know, but the point I'm making though is if you do it to the Health and Wellbeing Board, it can set wheels in motion. I'm not saying don't write to the paper, but you know,
yeah,
write to the Daily Telegraph. You know, we're actually specifically saying if we've got a range of issues and topics, you know, should we ensure that there's a Healthwatch question at every Health and Wellbeing Board, which sounds like a really good action point. But I would also encourage there to be joint questions from us and other organisations and what have you, and to scrutiny as well. You know, the scrutiny board is so new, it's not clear what it does. No one really knows it's even there. So perhaps it needs to fill its boots in terms of what it's there for. And it can be helped by people asking it questions, or, you know, the public is allowed to send them topics for scrutiny. But as far as I know, no one has.
Well, they don't know. You know,
no, it is chicken, egg, chicken, but no one knows. So we have to potentially perhaps start the ball rolling or encourage people to do this. But yeah, so I think it's about using vehicles that already exist rather than potentially going away and creating new ones. But let's absolutely utilise the space we have.
Karen, is that a question?
Well, I was going to say, I mean, Leslie's idea, a question at each meeting, I think is really important. And I don't know that it necessarily needs to be a Healthwatch question, because we are individuals. I mean, I'm trying at the moment. I've made a pact with myself to ask a question at each board meeting. And what I'm interested in is trends. And they don't seem to be able to provide trends, or don't seem to know how to analyse those. So, I mean, the questions are about each of the strategies. How will they, what improvements have they made underneath these headings? And how can they provide evidence of that? So by asking questions, it will just highlight them. They'll have to do something about it then. I mean, in some ways it's taking up time for them, but yes, but that's what they should be doing. So I think it's really important. If people ask us, what do we do on Healthwatch? We hold the local authority to account, would be brilliant. So press on.
Thank you, Karen. Right, is there anything else? Oh, that's an old hand. Is it Karen, or have you? Yeah, okay, fine. Well, if there are no further questions under any other business, I would like to thank everyone for everything they've done this year for Healthwatch, to say a sad goodbye to Michelle and Nathan and thank them for all the work they've done over these past 4 years. To be sad that we're not sitting around eating a mince pie as we might have done a couple of years ago, but I'm sure we can do that to our own heart's content, and to wish everyone a very happy Christmas, happy New Year. Keep safe, keep testing, and we will circulate dates for the next meeting, which I think will be in March, in due course. So thank you very much.
Thank you.
And Merry Christmas.
Happy Christmas.
Merry Christmas, everybody. Take care. Thank you.
Take care, everybody. Keep safe.
Bye.
Happy Christmas,
Bye.
everyone. Stay safe.